sure we'll have lots of questions at the end of our panel. The next person is going to be Enrico Coeira from Macquarie University, who's going to discuss the ability to replicate digital health research. Enrico.
Thank you very much. Thank you. Today I'd like to talk a little bit about what's actually an interesting side project. The overall theme for our Partnership Centre work is to look at analytics and AI and understand its role in providing high value care, helping us do things better, but also know what works and what doesn't work. And I think the focus today is to really ask a question, not about what is the evidence base for value-based healthcare, but how good is that evidence base in the first place? And as I go through this talk, I'll be focusing on digital health, but I want you to start to think about the quality of the evidence base in other aspects of health services research, not just in digital health. So this is my one slide summary of the value of digital health. And I don't want to go through each of these things in detail. The focus today really is down the bottom around decision support systems, where the research typically shows us that if you use decision support, we will improve the safety and quality of care. And whenever you read a systematic review that says something like that, they'll say that it's very hard to come to strong conclusions because there's such a variation in the quality of research that's done and the settings of the research and the types of systems that are being used. And so we rest upon a moderately good quality evidence base. When you look at the quality of evidence across all disciplines, people focus on something called replication. In other words, do the results of a particular study actually hold up if somebody else repeats the study? And you can see here some of the challenges. So this sort of research replication focus originally came out of psychology, where they did an attempt at replicating 100 of their major studies and found only about 39% of all these major studies could be repeated, that you would get the same results. And when scholars look at replication across all disciplines, the estimate is about 50% of all research that is published actually can't be replicated, which is a concerning number, and people are right to be concerned about it. One of the questions arises immediately: why can't we replicate research? And the common answers are that there are problems in the conduct or analysis of that original study. Maybe it wasn't well designed, maybe there were statistical errors, maybe the sample size was small, maybe the researchers were looking for things that were significant, what's called p-hacking, rather than actually trying to test a hypothesis. And also there are well-known biases to reporting unusual results, which might get the journals excited and make newspaper stories, but which, if they really are unusual, are probably not true. And from my perspective, I got interested in this because I don't know too much about the state of replication in digital health and biomedical informatics. And a couple of years ago with colleagues just wrote this piece here where we just asked the question, do we even know how robust health informatics research is? What is the state of replication? And the result of that paper was to say, look, no research actually has been done. So what I'm going to do today is report the first study that I know of on replication in digital health. And this is a paper that has been accepted, is in press. My hope is it appears online in the next 3 or 4 days. So you're getting a global scoop here. And what we did there was to try and focus on just one aspect of digital health, clinical decision support systems, which are those algorithms that our analytics and AI produce. And so this is the first survey that I know of any aspect of digital health in terms of replication. And to do it, we undertook a systematic review. We looked at the top 28 journals in medical informatics. And we just did a large search across them, looking for any paper, any research study that reported clinical decision support. And it had to be a clinical study. So we weren't worried about designs of algorithms on historical data. It had to be a clinical study. And a critical thing was that to be included, you actually had to be specifically trying to reproduce somebody else's results. You have to nominate that you were replicating and identify the study you were trying to test. And in the process of doing the study, we've had to make a few innovations, we think, in how one studies replication, which I'll talk about in a minute. But let's get to the headline results. So we found about 4,000 papers that were some kind of clinical decision support. We found about 10% of papers that could have been a replication. And then we went through those papers very, very carefully. And we found only 12 papers out of over 4,000, 0.3 replications. So that's an extraordinarily small number of papers trying to test prior research. The other headline result is that half of those papers could not reproduce the studies that they had set out to reproduce. Now, what gives me confidence in the results I've just told you is that I know that 50% number is what we find across other disciplines, so it's not a surprise. What gives me pause is that we're talking about 12 papers, which is a very small sample out of 4,000. But if this were to be representative of all of digital health, we'd be saying, look, you know, my goodness, potentially half of all our studies are not reproducible, which would raise alarm bells with anybody. So when you look at disciplines like psychology, their replication rate before they got worried about replication was about 1% of studies. So we're about 300% worse off even than that discipline where there were problems. So the question should be, we be worried? And the first half of the answer is, well, that rate of replication to me is a cause of concern. And I'll talk more about that in a minute. The second question though is, well, so what does it mean when I say 50% of studies could not replicate earlier studies? Does that mean the early studies were wrong? And this is where it gets complicated and interesting for an academic, because one of the main reasons you might not be able to reproduce a study's results was simply that in health services, we know we get different results when we go to different settings. If I try an intervention at one hospital and then I repeat that study in another hospital, I might get very different outcomes, different patients, different case mix, different workflows, different infrastructure, different training. All those variables might affect results. So the concept that I think is really helpful here, which replication researchers talk about, is whether we have a high fidelity copy of the original study or whether it's low fidelity. And if we're doing what's called a high fidelity study, we're trying to test the truth of that original study. So you did something with a particular piece of technology and you're doing exactly the same thing in exactly the same kind of setting. Well, we're testing whether that was true or not. But if we're doing it in a different setting with maybe some other variations, we're trying to test if that result there generalizes to where I am now. And if I fail to generalize, that may not mean the original study was wrong or not. So that's a very important distinction to keep in our heads. I'll now go through the fidelity study we did, and I'll take a little bit of time for this one slide here because it's really important, because it sort of explains in a sense that 50% failure result. On the left-hand side, you see we've got what we call our IMPISCO scale, which means for every study, we just looked at separately the investigators, the method, the population, what was intervened, the setting, the comparator, and the outcome. So it's sort of an extension of classic PICO. And across the top, you'll see that we had 5 different measures of fidelity. So everything from trying to do an exact copy of what was done, all the way through to conceptual studies, which try to vary and generalize, all the way through to really not trying to reproduce it at all. And what I've got here is it's sort of a heat map. I'm looking at this. These are the data for 6 papers, which all try to replicate one classic study by Hahn. And that classic Hahn paper had showed that if you used what's called physician order entry systems in pediatrics, you increase death rates. So it was a very scary result in digital health because it suggested we were harming. And none of these 6 papers reproduced that harm study. And what you can see here is a huge scatter between exact replication, which is testing truth, all the way through to generalization. So you can see a big difference in what they're trying to do. So what this data set tells me is that there was a lot of effort early on to try and test the truth of that, and it showed it wasn't true. And then there was a shift over time to try and generalize it from pediatrics to general ICU to hospital settings. And the last slide kind of shows that very nicely. So all I've done here is for those 6 papers is try to compress all that data into something that we've called a fidelity score, and I haven't got time today to go into that. But you can see over time that we started with some very high quality, high fidelity studies just to really test whether or not that hard study was truthful. But over the ensuing decade, people were more worried about testing generalizability over time. So I've never seen that result before. Nobody's seemed to look at this distinction before, and maybe the tools we've developed for this study around IMPISCO and the fidelity index will be useful. I actually think they're actually useful even for doing systematic reviews in a way, because often systematic reviews, when you can't do a meta-analysis because things aren't similar, we don't necessarily look at fidelity too closely. So I'll just finish up now because I know I've only got 10 minutes. But so what does this mean? So I think for my own field, it means we really need to get cracking on understanding whether or not these numbers that I've reported do hold out. Somebody's got to try and replicate what I've just done, I guess, is what I'm saying. And we need to identify which major studies do need to be replicated. It's not that digital health isn't working, but if we had a better evidence base, we would be building better digital health systems. One of the things I found was that it was very hard to find these replication studies. There was a lot of manual effort in identifying them. And I think some sort of a standard around structured reporting for replications would really help. For all of this to happen, actually, we're talking about culture change in the field. In other words, people tend to get rewarded for novelty and making new discoveries. We don't tend to reward researchers for going in and repeating somebody else's work to test it. And I think that has to change. And that also requires journals to change what they're doing, to not always just get excited by the latest new study, but also to really focus on publishing critical replications. And there's probably scope, I think, for the smaller replications, which probably need to happen to have smaller specialist journals. So I'll stop there, but I just do want to remind you that if you think this is a digital health problem, it's not. This is really an issue for most disciplines. It's just that I've focused today on the area that I know best, which is digital health. So thank you very much.
Thank you, Enrico, for that very challenging approach that you've taken for us. I think having confidence in the evidence is really, really important, and will require that sort of ability to go back and say, how can we replicate? How confident can we be in what we are being presented with? Our next speaker, once again, knows no introduction, Joanna Westbrook from Macquarie University, is going to give us a presentation on the use of electronic health record data in aged care to monitor and improve quality.